a hand therapist and a certified orthopedic manual therapist who's been practicing for nearly a decade. She's a UW Cross graduate and a continuing education instructor, and was just recently promoted from therapy manager to training practice administrator. Theresa will be discussing the evolution of flexor tendon rehabilitation. Please welcome Theresa.
I think that you worked out the kinks with the clicker, Dr. Olby, so looks like I got smooth sailing. So I got the last talk before lunch. It's always a tough slot, so hang with me here. But talking about flexor tendon rehab has mainly become exciting because of what Dr. Olby just talked about, that when you have a greater confidence in what happened in the operating room, you can have even more confidence when you're working with that patient post-op. So our goals for this talk will really be spending a little time looking back at where we've come from, what's the history of flexor tendon rehab, and how has it evolved over the years. It's changed a lot. It's a completely different animal than what it used to be. And looking at how these changes in rehab have focused on improving outcomes and function, and trying to reduce the risk of early ruptures as well as need for subsequent procedures like the tenolysis that Dr. Olby just talked about. And then taking a look at what the literature has to say about this population. Oh, it's a little too soon. So just a high-level overview of flexor tendon anatomy. When we talk about bending of the finger, of our long flexors, we have two tendons, the flexor digitorum superficialis, which will now be referred to as the FDS for the rest of this presentation. And it's responsible for bending the PIP joint. And it ends at the middle phalanx. And about 20% of us in this room don't have one in our small fingers. That may be just on one side, or it could be on both. So if we look at movement here I'm isolating my FDS by limiting movement from my other fingers, and there's my sad attempt with my small finger. I'm one of the 20%, no FDS for me. Oh, and there goes our flexion of the PIP joint. So there's the function of your FDS. Then, moving on to a more important muscle, we have the flexor digitorum profundus. So the deep tendon as it travels through the forearm, through the wrist. We have a splitting of the FDS that occurs and allows the FDP to continue and then insert on the distal phalanx. And it's our primary flexor. So big problem if we have disruption to this from either a laceration or a rupture. Important to note that this muscle has one shared muscle belly for each of the four tendons. And that's important to help patients understand why their entire hand is being held back after a repair of just one finger. So they have an injury with just their index finger, but they're limited with their whole hand. Because of muscle contraction, even if you're trying to just move your ring finger, for example, you're still going to cause some pressure on that repaired tendon. So here we can see we've got two tendons, FDS, FDP, entering through the flexor tendon sheath, going through the cruciate and annular ligaments, and we'd have a split around here for the FDS to finish up the middle phalanx, and the FDP continuing on to the distal phalanx. You can tell there's a lot of structures, small area, so how the introduction of something like sutures and then subsequent scar tissue, why that can be problematic and why it's important to look at a rehab program that minimizes that scar tissue so that we don't get too much bulk in this area that's already pretty full. So here's our movements. More of that movement at the tip of the finger. That's the function of your FTP. This is a model we have hanging around in our clinic. So you can see it's a finger. It has the structures in pink are the pulleys. So right now I'm going to start by pulling on the FTP. You see that that pulls all the way down to the tip of the finger. In comparison, if that's our FDS, we get just movement at that PIP joint to give you more of that flat fisting type of movement. So injury, again, to these tendons is a big thing. The significant significant functional issues, especially if it's that FTP, you're not going to be able to have a composite fist and require surgical intervention. So in this picture, this is more of a rupture type of situation. You don't see any evidence of laceration. And we've lost that normal cascade of flexion. So that resting position your hand typically falls in is now disrupted because that extensor mechanism is unbalanced by the flexors at this point. So as you can see by the numbers up here, the cost that's incurred from this type of injury is not insignificant. And that's for many different reasons. So we know that it requires surgical intervention and the recovery is slow. And it's not one that you can really, if you give a handout and say, do your best to follow this handout, see how it goes. You need to really be part of a rehab program and they have to follow the rules. So it can be frustrating for people. It also requires the use of a splint, something protective, and they have no use of their hand whatsoever for 6 weeks minimum. And it requires, again, that participation that often, especially in the early phases, they're exercising every 1 to 2 waking hours. So it's a workload. So looking back, if we go back to the 60s, after a repair, your rehab program initially for even up to 6 weeks is just immobilize it, let it sit. This is when there was the thought process more about we require extrinsic healing, so external scar to reinforce the repair before it's safe to put the load on it to induce movement. So we would end up having nice solid tendons, but nothing else moved, which does not lead to very functional fingers. So gladly we've advanced from immobilization. Into the 70s, we had the emergence of some new protocols like the Kleiner protocol out of the Indiana Hand Center. For the first 3 weeks, we're in the dorsal blocking splint. And what you're seeing here are hooks that are glued onto the fingernails and then attached with rubber bands. So what the patient was asked to do is to actively extend the height of the splint, because your extensor tendons are intact, they're fine. And then have the passive pull, I think that was me, sorry. The passive pull of the rubber bands pulling you back into flexion to facilitate some form of tendon glide. So this was asked every hour that they're going to extend and then actively be pulled down into flexion. And this really yielded predictable outcomes. Again, low risk or low rupture rates, but if you're resting in this position for a long period of time, the rate of PIP flexion contractures was not insignificant. And we all know, if you've been around those are a bugger to treat. So not overall great outcomes, even though it didn't lead to many ruptures. And this can be a tough sell when someone sees that you get out glue to put something on their fingernails. Also in the 70s, we have the emergence of the Duran protocol, which is also a passive protocol in a dorsal blocking splint where you're getting passive motion, but the focus was more on specific joint movement. So focusing on getting passive motion at the PIP, DIP joints, and then composite. And we started to get more of an understanding of glide and why glide was important to prevent scar formation and how you could achieve glide with even passive motion, so the muscle not firing. Into the 80s, these lists are always kind of concerning. So whenever there's a lot of options, it means that there are no home runs. Nothing is an excellent choice. So we continue to have this emergence of different proposed protocols. When could we start motion? And introducing the early ideas of early active motion. So again, our lists continue to expand. Probably the most notable of our early active protocols was Nancy Cannon in 1993 out of the Indiana Hand Center once again, which talked about really trying to incorporate synergistic wrist motion with our early active motion and using place and holds, where you passively bring the fingers down into flexion and then ask for an active contraction, which now the thought process has changed on place and holds as well. So to overview the bulk of protocols, up into the early 2000s, use of a dorsal blocking splint, almost exclusively, typically with the wrist in slight flexion. Initial exercise varying from passive to maybe some place and holds, very rarely being active. And then initiating real light resistance at about that 8-week mark, with the hope that they can fully use their hand between 10 and 12 weeks, depending on last 10, 15 years, there's really been a change in focus where the literature has been surrounding exploring what those repaired tendons can sustain in terms of load. How much glide can it tolerate? How many newtons of force can it sustain after being freshly repaired? So looking at how can we restore motion and function while minimizing the risk of complication and rupture. And we'll hear this concept about intrinsic versus extrinsic healing, that we need to promote that intrinsic healing of the tendon to help it build its innate strength back in, while not relying too much on extrinsic healing from external scar tissue, which just clogs the area up, structures start to stick together and lose their normal sliding. So that's the balancing act. How do we load the tendon, enhance the glide so that we don't get too much sticking, while making sure that we don't overload it so that we don't get gapping and then eventual rupture. So we have this idea of controlled stress. So what is the incidence of rupture? In the literature, you see a wide range of rupture incidences varying between 3 and 18%. So here's an image from Dr. Lalonde, who Dr. Oldie was talking about, and his therapist, Amanda Higgins. So we're looking at just your core suture of the two portions of the injured tendon. And if load is sustained by either a muscle contraction or excessive pull, if this is not prepared to take that amount of force, that's what's referred to as a gap. So you create a space in the tendon, which is not going to lead to a great outcome and potentially, likely, a rupture. So what do we know about the timing as it comes to a repair? So in the early days, that 0 to 5 days post-op, we really have just cell proliferation. The main thing we're relying on in terms of strength is the suture itself, that the tendon is pretty puny. It doesn't have much to offer in terms of intrinsic strength. After that, until that roughly 4-week mark, we have fibroblastic proliferation and disorganized collagen. So things are getting laid down. This is really our cautious period where we can't be confident as to what the integrity of the tendon is, and so we have to rely more on our clinical evaluation and what they're presenting at to determine what it can sustain. And after around 28 days, 4 weeks, the collagen starts to organize. So our timing becomes important to really understand where they're at in that process. So again, knowing that during that first week we have that loss in strength depending on the suture. And again, we could have spent a full day talk just on different surgical procedures. So we're talking just on, mainly appreciating that it was repaired. And then having a progressive increase in strength after 2 or 3 weeks. What's interesting though is that the amount of stress, it's correlated with how much weakening you have. So something that doesn't get loaded at all is going to undergo significantly more weakening in those early phases compared to something that's getting a good amount of controlled stress. So we reduce the amount of intrinsic weakening by providing load. And then we have maximum collagen synthesis at around that three-week mark, but still only at 15% of its normal strength. So still pretty, fragile in those days. So again, talking about the physiological importance of load, as it relates to intrinsics, it actually improves the tensile strength of the tendon. So by loading it, we can facilitate internal healing. We get better nutrition to the tendon by increasing the nutrition from the synovial fluid within that tendon sheath. And then extrinsically, we help provide a direction of force for those new fibers to be laid down in versus it being disorganized and causing more potential for sticking and getting caught on peripheral structures. And the better you're doing in this realm, the less you need that realm. So hopefully we can reduce the need for continued extrinsic scar formation. Then starting to talk a little bit about force. So we hear it spoken about in newtons, and it can be achieved by both active and passive range of motion. And we're always trying to find that sweet spot of what's the minimum amount of force we can give so that it's safe to still provide the amount of excursion we need in the tendon so that we don't get adhesions. So we know that 5 newtons of force gives about 2 millimeters of glide, which may be enough to prevent scar. So to give an idea of what that means from an actual movement perspective, we're looking for that sweet spot, again, of 5 to 10 newtons. So less than 5, we are not getting enough load to get those intrinsic benefits and the movement we need to prevent scar formation. Over 10, we're looking at the potential for gapping and even rupture. So a simple exercise, like a blocking exercise at FDS, like that first movement I was doing, that will elicit 13 newtons of force. If you're doing a joint blocking of just the DIP, that's around 23 newtons of force, where aggressive gripping is above 50. So it doesn't take much to generate force, which is why we've had to be so careful and calculated with movements in those early days, so that we can stay in our sweet spot, 5 to 10. So here, again, this is our model. This would be an example of passive motion. So you can see that the tendon moves somewhat, but if you compare the glide and slide that occurs with active motion, so the muscle belly pulling the tendon through the pulleys, how you get significantly more glide, but also more load. So again, it's that balancing act of movement without too much load to provide the gap. We've learned more recently about how the wrist impacts this process. So if you all put your wrist as far back as you can, make a fist. Now go as far forward as you can, make a fist. Which is more comfortable? That, right? So intuitively, if you're repairing a structure on the volar aspect of the wrist, it would make sense to position it in some flexion because now it's on slack. We're putting the tension on, or the less tension on the repair. But when you start asking that patient to move, it requires a larger contraction to induce the same amount of movement because we've taken away the muscle's mechanical advantage. So that's why you have almost kind of that crampy type of sensation when you're trying to flex in a wrist flex position versus in that extension position where you've picked up some of that slack and it comes down nice and easy. So we've now learned more about how slight extension positioning reduces what the work of flexion, so that's what that's referred to, is how much muscle contraction we need to achieve active flexion. So a recent study looked at 30 degrees of flexion in comparison to neutral. You have less force come across the tendon in that neutral position. And again, we can't negate the importance of what type of surgical technique occurred and as well as the other injuries that were incurred. So we're talking about a simplified process here, but just globally, that in a simple laceration, putting that wrist in a little bit of extension can be helpful. So the idea of what types of movements lead to additional force isn't new. This has been studied for years. This is a pyramid from Yale Growth, looking at passive motion being the least force, and then transitioning to things like isolated motion that causes more force. Where the questions that have been raised now are more about the idea of place and holds. Because if you put your typical place and hold exercise encourages full flexion and then engaging the muscle. And how that actually goes against your sort of native flexion patterns, because we typically don't have to deal with slack. So you can have exactly what Dr. Olby showed in his video, where things can get caught against a pulley because you created slack in the tendon by doing a passive motion first. So again, you can feel much more confident with what we're asking the patient to do, depending on the surgical technique, but also really appreciating the course that the tendon has to go through when it's passively placed somewhere versus actively being pulled. So how do we know? How do we know whether to give them more progressive exercises or to hold off? The importance really comes from looking at them every visit very critically in terms of what can the finger achieve passively and what can it do actively. And the difference between those two numbers are what is guiding your progression of a treatment plan. So if they have very little difference between those two numbers, so they can passively go down into a full fist, they can actively get to that same spot, we can feel pretty confident that they are very efficient with their gliding and that they have very little extrinsic scar tissue reinforcing the repair, which is great, but also a little nerve-wracking because, again, we have less reinforcement occurring. So that's going to impact how quickly we progress someone through their protocol, is how they're presenting. Do they have great active motion, or when you place them down into passive flexion, do they kind of have a recoil where they're not able to keep that finger completely down? That's more of our evidence of scar formation. So that brings us to sort of the most recent and hot protocol referring to true active motion, and that's coming from, again, Don Lalonde and his therapist, Amanda Higgins, in Canada. So this was published in 2016 and done with the assumption that the repair had taken place under Lalonde. So the surgeon had evaluated the repair in surgery. So how this looks is that the patient starts in wrist extension, and they are immediately allowed to do a half fist of active motion. So another researcher that was instrumental in kind of popularizing wide awake surgery with Jim Boateng, and he found that you really have a significant amount of increase in force, 10 times the amount of force in your final third of fisting, so that you don't have to get into that range in order to achieve glide. So you can do a gentle half fist, still get between 5 millimeters and a centimeter of tendon glide to avoid that scar formation and apply safe load. So that's the starting point, is a half fist, and I'll show you how this looks when you're asking a patient to complete it. At around 2 weeks, you can reduce the length of their splint so that it allows for full wrist flexion, so that the movement can happen a little bit more synergistically when you get into wrist extension. The idea then is that by 6 weeks, you've increased the amount of fisting to a full fist. So they're starting at a half. A couple weeks later, depending on how they're doing, they're starting at maybe 2/3, getting to 3/4, and then eventually, as you feel confident, that they can get to a full fist. The idea is that you can reduce the need for subsequent procedures, which is always our goal, getting people back to function as quickly as possible by following this. You would still do this same goal if you're following a different protocol. And so that's really one of the take-homes, is that it's less about the protocol you start with, and it's more about how you are monitoring the patient and progressing them through. That's really the key point. So taking a look at some of the literature, in 2018 there was a systematic review that was out to look at, what does the literature support in terms of exercise regimes post-op between early passive motion, place and holds, and true active. So the results, they found that early active motion and combined Kleiner and Duran protocols result in low rates of tendon rupture and acceptable range of motion, but really that there were no randomized control trials. This again is largely because these often don't happen in isolation. They're crush injuries, they're done in combination with vascular repairs or digital nerve repairs, so it's hard to study tendon repairs in isolation. And they came out with no recommendation of one protocol over the other. So not super helpful. Another Cochrane review last year in 2021 again found a lack of evidence from randomized control trials on most rehabilitation interventions used following surgery for flexor tendon injuries. All right, not that helpful. So what's this telling us is that there's no one-size-fits-all for rehab. It's really about getting these people in the hands of a skilled therapist who's going to monitor them at every visit. So active and passive motion at every visit so that can guide the progression of exercise. And that's going to be the type of exercise, how frequently they exercise, the splint position they're put in, how quickly we get them out of their splint. So that's really the key piece versus the type of protocol that's chosen initially. So some general progressions. Again, we have no literature supported gold standard. There is definitely the trend towards the more active motion protocols, and from our biomechanical knowledge, that makes sense. But it's really still very heavily guided by a skilled therapist to move within the constraints of a protocol. And it becomes more fluid. So again, you're progressing forward. If they are showing signs of getting more stuck, you're slowing them down. If they have excellent active motion right off the gate. So we want to load them up. If they're showing that lag, they're not able to actively get there, slow them down. And I usually end up drawing this out for patients, that in the bell curve of motion, you'd like to find yourself right in the middle, where you don't want to have excellent motion. You know, we all have people that want to be the standout star. You don't want that when you have a flexor tendon repair, because again, it shows that you don't have a lot of extra scar tissue reinforcing, which is a good thing, but also makes it a little bit more risky, and you don't want to be on the stiff end. So following or getting them to sit in that sweet spot is ideal. Challenging, but ideal. Overall, our trends, again, are working towards early active motion, finding that placing the wrist in a neutral or slightly extended position is able to reduce that work of flexion. And then also working on your ability to impact the work of flexion from external forces as well. So things like edema control right out the gate, doing your best to keep bulky dressings at a minimum whenever possible. Again, depending on the types of injuries that have occurred in combination, not always possible, but you can envision how much harder it is to move a finger that has an extra inch or centimeter of dressings surrounding it. So again, considerations, other injuries, what's the strength of the repair, how many core strands were used, was it a grinder type of injury where there may have been some tendon loss, and then the repair is under a little bit of tension. All of those factors have to go into how quickly you're going to progress this person. And then also just the people stuff. How well are they? What's their capacity for healing? Do they have diabetes? Do they have a good nutritional regimen that their body is getting the nutrients that they need for healing? And then we talked about how work intensive some of these exercises can be, that they're doing exercise 8 times a day, and is everyone going to comply with that? And then also how heavy are their work tasks that we're trying to get them back to? So this is a patient that was all too excited to be able to share his progress. So he had a laceration of his small finger trying to separate 2 frozen objects with a knife, slipped and lacerated his FTP. So here was his starting position. So we followed the St. John protocol. The doctor was a little concerned about quality initially, so we held him back a week. So that was our modification early to make sure that we weren't progressing him too fast. And so we had him doing passive motion, like we saw with that Durant picture, so just gentle passive movement in addition to active motion at a half fist. So if you have your patient put their opposite hand perpendicular to their palm, and you say gently scrape till you get to your middle finger, that serves as a good template for half of a fist, because it can seem kind of arbitrary in someone's mind and they don't necessarily do it the way you want to initially. Then we reduced to that Manchester short splint so that he could do it in combination with wrist motion. So flexing at the wrist and then coming back into wrist extension. Here I started to get a little bit more concerned, so let me back it up. Because he has less FTP glide, so the tip of the finger isn't bending as much as you can kind of see. At this point, he was pretty swollen, so wanting to manage his edema. You can see here, there's some paint on his splint. So some concerns that, and he wasn't using his hand, but he was just being very active, so creating a lot of swelling globally and it resting in his hand. And that definitely impacted the ability for his tendon to glide. So for him, again, it's about being specific specific with how you progress him. I didn't want him to exercise more frequently necessarily to not further increase the swelling, but he needed to reduce his other activity to ensure that that swelling came down. So now it's starting to look better. We got more of glide happening at the DIP. Here it is again. And so this would be considered more like that 2/3 to 3/4 fist that we're working in. And then he's able to start doing it completely without the splints, and he's got excellent motion overall. So our takeaways is again to appreciate that we're trending away from passive range of motion protocols exclusively and going more towards protocols that incorporate active motion early and may place the wrist in more of an extended position. And again, a point that was frustrating when we were doing more strictly passive range of motion protocols, we were finding that people who cheated a little bit and used their muscles would actually do really well. So again, it just makes intuitive sense that some active motion early is helpful to, again, load the tendon and create extra glide. Advances with surgical technique and our biomechanical knowledge have coincided with protocol and exercise changes. It's important to understand what load each exercise applies to the tendon and where they're at in their phases of healing. Their presentation clinically always trumps the protocol in the hands of a skilled therapist who's got the communication with the surgeon that was in there to see what's happening also. So you can't be stuck to the protocol, it needs to be fluid. We have to consider patient, tendon quality, and surgical technique when choosing a protocol as well.